background here in terms of the Lancet Commission because I can tell you 4 or 5 years ago I wasn't sure what a Lancet Commission was, and I wouldn't expect you to necessarily understand that. So I would say about a little over a decade ago, Richard Horton from the Lancet started this commission process, and it was really ingenious. And every year or so, he picks a topic that he thinks is important for global health, and he has a commission on this. So there have been a number of commissions. There was one on healthcare education. There was one on investing in health. Every year, actually now there are more than one per year. Ours started about 3 years ago, the Lancet Commission on Global Surgery. Now, when you meet with Richard Horton, he's very specific and he says, look, these are not just meant to be dry academic documents. This is not a review of the literature. We want this to inform and change policy. So he's very clear about that. That's Richard Horton there. And when we met with him the first time, he was also very clear and he said, this is what I would like you to do. One, what is the status quo of global surgery right now? So what's going on, all right? Define that. Come up with some key messages. And he said, I don't want 24 of them. I want a few understandable key messages. Clear recommendations. And he said something which turned out to be really, really insightful. He said, I want some indicators or metrics for global surgery because he knew what we found out, which is there was no good data around global surgery. And he said that to us, and Jim Kim said the same thing. And again, he reiterated this over and over again. This was supposed to be an active document that changed policy. So that was the charge that we were given. Now, I'm going to walk you through, I'm going to tell you the story of the Lancet Commission. And this is kind of a two-part talk. I'm going to do that. And then the second part is to tell you what's happened since this was published in April of 2015. Because it's nice to publish the document, but what has actually happened with it. So one of the first things we did, which turned out to be a good thing, is in our very first meeting, which was literally almost to the day 3 years ago in Boston, we came up with a vision: universal access to safe, affordable surgical and anesthesia care when needed. Now that turned out to be important for a couple reasons. One, that was somewhat of our true north. So our group, whenever we were arguing or debating about things, we would say, well, hold on, is this approaching the vision for the Lancet Commission? So it helped keep us, on the right direction. And the other, you'll see one of our key messages actually picked this apart, the multidimensionality of this vision. And you'll see this in just a minute. Our first key message actually played off of this very importantly. Now, most commissions, they usually have about 3 meetings in different parts of the world, and we did that. We had the first meeting in Boston, the second in Sierra Leone, literally right before Ebola took off, and then we had a meeting in Dubai. And we did something a little different than other commissions. We had a 4th meeting with an entirely new group of commissioners. So we brought in a whole group of new folks, mostly USAID, NIH, ministers of health, et cetera, because we had roughed out the document by this time. And what we did when we met in Bellagio is we gave them the rough copy that we had, and we said, okay, what are your impressions? How does this play to you? If you have to take this to your minister of health, what is going to be the impression? And this turned out to be a really important meeting because it helped change some of the things we were doing and focus some of our efforts. And I'll explain that in just a minute. The other thing we did, which turned out to be very important, is we had a number of regional meetings because we did not want this to be just 25 academics that met a few times and came up with a document. And so this turned out to also be very important. Now, wow, that's really colorful. So this is schematically what the Lancet report looks like, just so you have an idea. In the background are the 4 working groups. So healthcare delivery management, workforce, finance, information management. And I should tell you, actually, Toronto had a lot to do with the Lancet Commission. So some of you may know Anna Dare. She led this working group and wrote most of this section. So she was critical. And the other person who was critical is Josh, who's up there in the corner there. Josh helped a tremendous amount, and I'll show you some things that he did later. So Toronto had a lot to do with this Lancet Commission. Now, we did what Richard asked us. We came up with some recommendations. On top of all this, what bubbled up to the top are what I think were the 4 most important things to come out of the commission, and I'll go through those in just a minute. Now, what I'm really happy with is what started as 3 chairs, so Lars Hagander from Lund and Andy Leather from King's College and me, ended up being a collaboration with folks from 110 countries and universities, over 100 publications, abstracts, and teaching cases, which was huge. And I won't spend any time on this, but I will tell you, we pulled a little trick from business school, and we had a number of teaching cases written because, um, if you've ever seen our commission or any commission, quite honestly, it's not the type of document that's easy to teach a course from. It's a little dry. Ours is fascinating, of course, but they tend to be a little dry. So what I wanted are some teaching cases that schools of public health, even business schools, that some of them have been used in business schools, can use these to get to specific points in global surgery, whether it's leadership, supply chain, et cetera, et cetera. All right. And these are also freely available on our site. And the other thing we did, which was a little different, is we went to editors in a number of different journals and said, hey, we're doing this with the Lancet. Would you be okay with accepting a number of global surgery articles that are then going to feed up into the Lancet Commission? And that's how we ended up with so many publications and abstracts, which was critical because, as you can imagine, if you only have one publication, if it's just the Lancet Commission, you can't have 100 authors on that thing. But we ended up really being able to get a lot of people across the world involved because they could publish things in other journals, which then had a little asterisk, and that fed into, and that became the references for our articles in the Lancet and Lancet Global Health. So right before I really get into it, I'm going to have you listen to Jim Kim. So he gave an address 3 years ago in Boston, the first meeting, and then about 18 months later, he gave an address at our official launch. This is the second of those two, all right? So he had access, he had looked over the document, and you'll see he does a fantastic job of summarizing some of the key issues, and then I'm going to unpackage those a little bit after he does that.
Thanks so much, John. Greetings to everyone, and sorry that I can't be with you in person. Congratulations especially to the Lancet on the release of Global Surgery 2030. Today, an astonishing 5 billion people cannot get safe, affordable surgical and anesthesia care. 90% of people in low and lower middle income countries can't even get basic surgical care. The Lancet's report shows us how we can close this gap. Its proposed time-bound indicators, for instance, are critical. They can motivate governments to provide the universal and affordable surgical and anesthesia care that people deserve. The stakes are extremely high because failing to fix this problem will have a substantial impact on people's lives, well-being, and even on their economic health going forward. 33 million people face catastrophic health expenditures due to payment for surgery and anesthesia care each year, and an additional 48 million cases of catastrophic expenditures are attributable to the non-medical costs of accessing surgical care. That's 81 million people that are plunged into poverty every year. There's also evidence that low and middle-income countries will suffer enormous losses in economic productivity over the next 15 years if this access gap persists. For these reasons, the Lancet report's findings make an important contribution to global public health. They're also an essential step to people living healthier, happier, and longer lives. It shows that we have to think in a fundamentally different way about healthcare and surgery's role in it in developing countries. Not only is access to surgery the right thing to do morally, it's also important to ending extreme poverty and boosting shared prosperity. I want to thank my good friend John Meara for his leadership on this effort, and thank everyone at the Lancet for doing such good and important work for the poorest people on the planet.
So Jim did a really nice job, you'll see, of summarizing a number of the main points that came out of the commission. I want to spend just a minute to unpackage those because he gave them to you in rapid succession, and I want you to have an understanding of where they came from. So our first key message was that 5 billion people don't have access to safe surgery when needed. And what we mean by that is they don't have the same type of access that you and I have. If after the lecture I fall and break my wrist, I'll get taken care of immediately. All right? That's not the type of care that almost 5 billion people in the world have. All right? That's just the reality. Now, the reason that came up, and I link that to our vision, because Atul Gawande, it's probably been 6 or 7 years ago, his team came out with the number 2 billion a number of years ago. And that came from looking at how many hospitals had pulse oxes. And they said, well, that's a proxy for safe surgery, which is great, but that's just one piece. So we tore apart our vision. And you remember there were several parts to our vision. And we said, well, okay, let's talk about our vision. There's a timeliness component. So how many people can get to surgical care when it's needed? If you need a C-section and you're 14 hours away by donkey, that's not the kind of access that's appropriate. Now, what if you can get there, but you get to a facility that doesn't have the capacity? It could be for a number of reasons. They don't have electricity, they don't have sterilization, et cetera, et cetera. Now, there are some people that can jump through both of those hoops, but they get there and it's not a safe environment. So they don't have a pulse ox in the OR. All right? They don't do timeouts. They don't have M&Ms. They don't have a culture of safety. All right? That's not good either. Now, there are a number of people that can jump through all three hoops, but this is what really knocks out a lot of people, is the affordability. So they can get there, they find a hospital that's not bad, but quite frankly, they just can't pay for it. And even when it's supposedly free health care, they still sometimes have to buy their own antibiotics, their own sutures, et cetera, et cetera. So it's not really free. So we looked at that and modeled that using that thought process. And here's the heat map of this. So the darker the red, the closer it is to 100% of the people in that population that don't have the kind of access that you and I would want for ourselves or for our family. All right? So not surprising, there are some areas where literally 95, 96, 97% of the people get caught up in one of those hoops that they're trying to jump through. All right? Now, the next thing we looked at in terms of access to surgery is workforce, and tried to get some idea of, is there a relationship between workforce and outcomes? And I want to spend just a minute or two on this. So we came up with a concept of SAO providers, surgeons, anesthesiologists, and obstetricians per 100,000 people. And that's on the x-axis. So you can see 10 SAOs per 100,000, 60 SAOs per 100,000. And we worked with the WHO and to the best of our ability, went country by country and got that data. And then what we did is we took available health outcomes from the World Bank. And honestly, you can take any of the available health outcomes and the curve looks pretty much the same. Now, I'm quick to point out, this doesn't prove causality. So not for a second am I saying that if you double the healthcare workers, you're going to have the maternal mortality. However, Richard Horton said, what does the world look like? And this helps us get an idea of what the world looks like. Now, it's interesting to note that countries that are above about 40 SAOs per 100,000, it doesn't look as if their health outcomes are that much better or different, all right? And the other interesting thing is below 20, that's where you start to see some problems with any of the health outcomes that you plot. So it seems like maybe something is happening between 20 to 40. Now, just to give you a frame of reference, the US, actually I think the US is over in the corner there in terms of SAOs per 100,000, all right? So 20 to 40, that's not an unreasonable ask. Now, to give you the other end of the spectrum, there are many countries that have 1.2 SAOs per 100,000. That means they don't even have all three of those folks per 100,000. All right, so that's where the world is right now. Some countries with way too many, some countries with 1 or 2 per 100,000. All right, there's got to be some number that's a little bit more normative. Second thing we looked at is procedures. So there are about 330 some million surgical procedures performed in the world today. And we said, well, what would it take to bring those low and middle income countries up to kind of a normative range? And it turns out we're short by a lot, 143 million procedures. Now, why is that? Well, not hard to believe that number when you realize that the poorest third of the world's population only receives about 6% of the world's procedures. All right, so you have incredible disparity. US, 25,000 procedures per 100,000. Low income countries, way less than that. And that's what I'm going to show you right now. So we also did the same trick looking at surgical procedures. So this is procedures per 100,000 folks, 100,000 population, and we did the same thing charting it against available outcomes. And you can see same type of thing happens. Below about 5,000 cases per 100,000 people, these are countries where health outcomes are not so great. Above about 5,000, it doesn't appear that more is better. All right, the US actually is over here. US is about there. We do about 28,000 surgical procedures per 100,000, all right? And you notice that our health outcomes in general are no better than countries that do 6, 7, 8, 9, 10. Now again, you can't prove causality, and I'm not saying, certainly wouldn't tell you that more is better. And honestly, we don't even know where the exact number is, but for the Lancet Commission, we picked 5,000 and said, what would it look like? What would the world look like? What would it cost if we got countries to 5,000? Just because it seems like that's where things start to change. Now, I want to explain this to you. So we borrowed an approach from the maternal health world called the 3 delays. So and you'll see this in our Lancet Commission, we looked at surgery using the 3 delays. So the first delay in seeking care. Why do people delay in seeking care? All right. The second delay, what are the delays in reaching care? So they make the decision, I need care. What keeps them from getting there? And then the third delay is they show up at the facility, and what is the delay in receiving care? All right, and it was just helpful. You'll see in the commission, we look at causes and then have specific solutions and recommendations in each of those areas. Now, the reason I showed you this, one, just so you'd have an understanding of the approach we took, and two, when we were looking at third delay issues, we worked with the WHO and we looked at their data on district-level hospitals. And it was interesting to note that there were 3 types of procedures that were somewhat prognostic indicators of district hospitals that could perform like kind of real district hospitals. All right, so the district hospitals that could do cesarean deliveries, treat open fractures, and do laparotomies, they had the capacity to do a much broader range of procedures, and for lack of a better term, they kind of functioned like a real district hospital, the way a minister of health would want them to function. And the reason that's important, as simple and basic as that seems, is I've had a number of folks from ministries say, okay, John, you guys did this Lancet Commission. Tell me something practical that I can take home. And this is pretty practical. Look at your district hospitals. If they're woefully inadequate, if they can't do these things, they probably can't provide a broad array of surgery that a district hospital should provide. So if you want to just start with some of your district hospitals and make them capable of doing this, this, and this, that's a nice place to start. It's a nice platform. And I'll show you a country that actually used this. Key message 3. 33 million individuals face catastrophic expense paying for surgery and anesthesia. All right, those are the people who pay for surgery and anesthesia. It doesn't count the people who give up. It doesn't count the first delays and the second delays, the people who just don't make the decision or can't get there. Now, the other interesting thing is this 33 million is just people who actually, for their medical cost, all right? If you look at non-medical costs, travel, et cetera, lost wages, it looks more like 81 million. And I will be honest with you, I think that's a gross underestimate, but that's what the data showed. Now, to put this in perspective, I lived and worked in Australia for about 5 years, and this is almost 4 Australias, rather. There's about 20+ million people there. So it's almost as if 4 times the population of Australia every year is being plunged into poverty or further into poverty because of surgery. Not hard to believe when about 3 billion people live on $250 a day. So if someone has to pay $600 or $700 to have their femur fracture fixed, it doesn't seem horrible to us maybe, but if you're living on $250 a day, that's catastrophic. Key message 4, and this, we really honed in on this partly as a result of that Bellagio meeting. So a lot of the people that were in ministries of health, they said, we love your messages, but look, the reality is I need to walk across the hall and go to my minister of finance because that's where I'm going to get the money. So you need to help me prove to my minister of finance that this is a good investment, that it's not just an expense. So that's what we worked on. Now, again, we modeled up what would it cost to bring district hospitals in low and middle income countries up to some normative range, looking at the numbers of providers that we had talked about and the surgical volume we had talked about. And it's a pretty frightening number, so $350 billion. Now, that's over 15 years, all right? Stanley and I were just talking about putting this into perspective. So the U.S. spends over $3 trillion a year just in healthcare. This is 1/10 of the U.S. healthcare budget for 1 year. So if we just reduce the U.S. healthcare budget by 10% next year, we would have enough money to pay for all of the low and middle income countries for the next 15 years. So just to give you some perspective, yes, this is a big number, but it's not inconceivable to be able to do something with that. Now, the good news is we also did some impact analysis. What might that mean to these countries in terms of GDP? So if you're 18 and you have a femur fracture and you are lost from the productive workforce, that has an impact on your country's GDP. Now, the good news is that if you were to magically start scaling up surgery, it could have a fairly substantial, on the order of $12 trillion impact on GDP in these countries. Now, another way to look at this, some of you may remember Jeff Sachs published this in '01 looking at the burden of malaria, and he said he modeled that about 1.3% of GDP was lost from malaria in emerging economies. And people thought that's horrible, that's intolerable. So we did something similar. We looked at surgery, and as you approach 2030, if you ignore surgery, if you don't scale it up, if you just leave it as it is right now, with the emergence of NCDs and what goes along with that, we may be talking about close to 2% of GDP loss from unattended surgical disease. All right, so it's pretty substantial. And this fifth key message, Stanley mentioned this. This actually is something that Jim Kim said in his very first address 3 years ago in January in Boston, which is surgery is an indivisible, indispensable part of healthcare. Now that doesn't seem like necessarily a significant statement, because we probably all think, well, of course surgery is part of healthcare. But up until that point, there really had not been someone in his position. You could argue maybe Houghton Mahler from the WHO years ago, but aside from those two, there hadn't been people who had stood up and said, surgery really needs to be part of healthcare. It should be part of universal healthcare. It is an integral part of healthcare. So that became our fifth key message. So now, just to explain the indicators. So Jim Kim asked us to do this. Richard Horton asked us to do this. We did that. We came up with 6 indicators, which at first glance, I'll explain those to you, and you think, wow, those seem fairly simple. Is that the best you could do? These are conceptually understandable and simple. They're not that easy to collect because many of these countries don't have the systems to do this. All right. If you go to Haiti and go to their health ministry, they can't give you this data. So it means changing the culture of data, surgical data. Indicator number 1, 2-hour access. So what percentage of the population is within 2 hours of a facility that can provide those bellwether procedures that I talked about? So the purpose of that is to give governments and ministries an idea of where is their population, where are their facilities that can provide those bellwethers, and how close are they? Again, no country's going to get to, not every country is going to get to 100%. We don't necessarily want that. But it helps governments and ministries understand where are my people, where are my facilities. SAOs per 100,000, surgeons, anesthesiologists, obstetricians. So this just gives governments and ministries an idea of how many surgical healthcare workers do I have, which is data that's not always available. Surgical volume, so how many procedures are performed in a country. Seems pretty simple. I mean, any business is going to know how many cars they produce, how much oil they produce, how many erasers they make, whatever the case might be. You would think that a government should know how much surgical product it produces in a year. POMR, perioperative mortality. So where are your people? How close are they? What's your workforce look like? How many procedures are you producing? And what's the mortality after these procedures? It's kind of the most basic, safety metric. Now, all of these are fraught with issues, and we could and did argue about these forever, but it's a start because none of this was collected in the past. Now, the number 5 and 6, impoverishing expenditure and catastrophic expenditure. These are critical because Mark Schreim, who's our research director, his PhD was actually around financial risk protection in surgery, and what he found is that if you scale up surgery and don't take account of financial risk protection, you can actually impoverish people and not get the benefits that I just talked to you about. So what we're telling governments is don't do that. Don't scale up surgery without addressing the financial risk protection, because not only are you not going to get the economic GDP benefits, you actually might go backwards because you're impoverishing people. So this is extremely, extremely important. National Surgical Plan. Now, don't try to read that. That's on our website. The concept here is that we came up with an idea that maybe ministries of health should have a plan for surgery, all right? Jim Kim said that it's an integral part of healthcare. Maybe not only should they have a plan, but it should be part of their national health plan, which again, probably doesn't sound like a crazy idea to any of you, but it just has never existed, all right? And we just offered some examples. So, an approach. What should you look at in terms of infrastructure, workforce, delivery, financing, information management? And we had some recommendations and we had some assessment methods. And this is not meant to be a cookbook, and I'm always careful to tell people in ministries, do with this what you will. Assess your country the way you will, this just gives you an idea of the types of things that maybe you should think about looking at. And I'm going to show you some examples of what's been done with this. So the next question comes up. That's great. In April of 2015, we published this. What's next? All right, and I'm going to show you some examples of what's happened since then. So this is Bellagio. Tough gig for us in the Lancet Commission, huh? So this was January or February, about 2 years ago, and this is where we brought in those new commissioners. And we said, A, how does this rough document look to you? And the other thing we did is we said, B, what should the Lancet Commission try to do post-publication? What is our role? And they were pretty specific. They said, it would be nice to help drive coordination between research advocacy and implementation. So helping countries take the document and actually implement it. Providing countries and health systems with the assistance that they need as they define it. So now one of the folks that was at that meeting said, don't come to my country and tell me what to do. We just might need some help in analyzing the data or help around adapting, the Lancet Commission. But we don't want you to come like a consulting firm and just, do it for us, which I thought was very important. So I'm going to show you in 4 areas what's happened since April of 2015. And the first is this concept of global indicator initiative. Now, why are indicators so important? Why did Jim Kim mention that? Why did Richard Horton mention that? You may have heard this saying in the past, you can't manage what you don't measure, and people have attributed that to James Harrington or Peter Drucker. But the point is, if you're not measuring what you're doing, you have no idea what's going on. And that's really, that was and still is the case in surgery. I mean, most countries, honestly, they really don't have a good grasp of how many cases they're doing, what kinds of cases, what their workforce looks like, even, what do all their district hospitals look like, all right? So I'll tell you the backstory to this. In that very first meeting 3 years ago in Boston, when we finished the meeting, I had an environmental economist come down, and his name's Jeff Vinson. He's from Duke. He's an environmental economist, not in healthcare. And he said, 30 or 40 years ago, in environmental economics, we were kind of in the same position because we didn't have any data. And it was hard for us to mount a case about climate change, environmental issues, et cetera, et cetera. And so what we did is we lobbied the World Bank to get a lot of new indicators in the WDIs. So the World Bank has a website called the World Development Indicator website. You can Google it, World Bank, World WDI site, and you'll find all these indicators. And he said, you ought to really think about talking to them and maybe seeing if you can get some indicators on the WDI site. He said, because what happened is a lot of PhD students in environmental economics then would pull down data, and they've done their PhD theses on things related to data that they had access to. So here's the WDI site. There it is. This is what it looked like up until April of 2016. So they have all sorts of interesting things. They have health, infrastructure. There's probably 20 different categories, to be honest with you. But you notice they have prevalence of stunting. They have teenage mothers who have children. They have unmet need for contraception, prevalence of HIV. But you will not find the word anesthesia, obstetrics, or surgery on there. Actually, there might be something related to maternal health, but certainly not the word surgery or anesthesia. Now, that fortunately changed in April of 2016, largely actually due to Josh's work. So Josh spearheaded this, and it would not have happened without him. He was like a dog with a bone. He just would not let go of this and saw it through to the end. Now, they said, great, if you can just collect the data for us, we'll take it from you. And they gave us 3 months to do this. So that was his task. I think we met with them in June, and they said, yeah, we'll need the data by September, October. Great, only 190 some countries to collect data from. That shouldn't be too hard. But he did it for 4 countries. So if you look at the website now, you will find on that WDI website SAO density, surgical volume, and data around financial risk protection. The 2-hour access and the perioperative mortality, honestly, were just impossible to collect in that time frame. We're still working on it. We're doing a round 2, so we're hoping to have another set of data for the World Bank. But for example, 2-hour access, knowing where your population, that's not too hard. But knowing what each of those district hospitals is honestly and really capable of, that usually requires a site visit. What instruments do they have? What's their workforce look like? Do they have 24-hour OB care, et cetera, et cetera? So that's a tough one. And that does require a culture of change. So it requires ministries of health saying, I want to collect that data, therefore I'm going to start asking for that type of data. Perioperative mortality, much the same. That requires a ministry that says, I want to get that data from you. All of my district hospitals, I want to know how many people die, while in hospital after a surgical procedure, and that's just not been the culture up to now. That's actually Josh's picture right there. So the World Bank, on their data blog, they published this, and there he is. He's your own Toronto native, famous. I give the World Bank a lot of credit. They could have said, no, go away, we can't do that. They could have said, all right, give us the data, and they could have just published it and never said anything more about it. But they actually were very active in getting this data out. So I really am indebted to the World Bank for doing this. I think it's helping to change the opinion of surgical data. Number two, single country studies. So up to now, we've been talking about looking at lots of different countries and possibly, what does one country look like in comparison to another? But what you realize when you start to do this, it's really important to take it to the next level and look at subnational variation. All right, so here's Brazil. We figured out that with 14 data points, you can basically get at the 6 Lancet indicators. And so we did that in Brazil. Nivaldo Alonso is one of our commissioners, and he helped us. And the different colors for these states show you how different the SAO density is, which, again, no one will be surprised with, but it wasn't data that was known. So, for example, one of the states has 11 SAOs per 100,000. Brasilia looks a little bit more like New York City in terms of SAOs per 100,000. The national average is 34. All right, now that's okay, and that's fine as a national average, and we should be publishing national averages. But if you live in this country, you need more than a national average. If you're the governor of Amazonas region, you don't need an average. You need to know in the Amazonas region what does your data look like. So this was a great learning experience for everyone, that national data is great, but subnational variation is what really tells the story. National surgical planning. So I love this story. This happened again in Bellagio. So I don't think we had even made the decision that we were going to have a national surgical plan when we went to Bellagio. That was one of the latest things that we made a decision about. So in Bellagio, we were talking about national surgical planning. There were about 20 people in the room. And we went on to another topic. And about 15 or 20 minutes later, down at the end of our table, Emmanuel Makasa, he's the Zambia's rep to the WHO. Emmanuel's down at the end of the table, and he just had his hand up. He wasn't saying a word. And so I saw him down there. I said, Emmanuel, can I help you? And he said, yes, I have just been texting with my government, and we would like to be the first country that works with the Lancet Commission on National Surgical Planning. He said, wow, that's great. And I thought, God, I wish I could text my government. Nowadays, I'd really have some choice things to text them, but so really impressed. I mean, Zambia was serious about this. Their government made a decision. Their Ministry of Health said, we want to do this. Not only do we want to do it, but we want to do it by the end of 2016, which seemed impossible. So this is our group in Boston. We helped them. FET from the UK and DFID provided funding. And believe it or not, much to my surprise, they did it. And it showed how important local ownership of the project was, because they made a commitment and said, come hell or high water, we are going to do this, all right? To the extent that, actually I'll tell you that in just a minute. Let me tell you what they did. So this was kind of the 30,000-foot framework for how we wanted to tell countries, look, this is how you should approach national surgical planning. There's a preparatory phase where you need to do these things. You should have some type of a big national surgical forum where you meet and discuss things and have stakeholders, and then obviously there's going to be an implementation phase. And Zambia said, oh, that's great, thank you very much, but we'd like to do this. Now, I think this is really, really important, all right? Every country needs to look at our national surgical planning document, all the things in the Lancet Commission, and they need to make decisions. How do we adapt this for our country, all right? This is really, really important. And what they did is they actually had a writing workshop where they pulled in stakeholders, ministry folks, and they almost locked them in a room for a week. I mean, it was almost like that. And they ground through writing that document and saying, this is what our national surgical plan is going to look like, and no one's leaving until we're done, all right? Then they had this big open forum where they invited all stakeholders, all right? And this is mostly ministry folks. This is one of our fellows who was helping facilitate. And then they had a costing workshop where they did the same thing. They brought in all their finance folks and they said, nobody's leaving until we cost this darn thing out, all right? And you know what? Now they have this, all right? And within a week or two, I am told they're going to sign this into law. And so as far as I know, and I could be wrong, but as far as I know, this is the first and only national surgical obstetric and anesthesia plan that is going to be intimately integrated into their national health plan. And the other thing I like is that they added obstetric and anesthesia. So I think you really have to be careful about being inclusive, and it was probably short-sighted of us just to call it a national surgical plan. Now, the next thing that's come out, I didn't necessarily see this coming, and I'm glad it did. So these are slides that I borrowed from a friend of mine, Glenn Guest and David Waters from the Royal Australasian College of Surgeons. So I went to give a talk there in October of 2015, and I presented the Lancet Commission, and they went away, RACs and all the Pacific, oh, I should tell you, it was a meeting that they invited all the Pacific Island folks to, that meeting. And so at that meeting, they said, okay, let's make a commitment. We are going to meet in Brisbane at the RACs meeting in May of 2016, and all of us are going to have data on the Lancet indicators. And you know what? They all did that. All of those island countries got together and pulled that data. So here's all the people that represented these countries, and RACs helped them do this. And in green are the Pacific Island, the Australasian countries. The yellow, that's data that we had pulled already for the Lancet Commission. But it just kind of shows you, this is the 2-hour data, all right? So remember, what percentage of your population is within 2 hours of a bellwether hospital, all right? Look, Nauru, small island, so theoretically speaking, most of their folks are there, all right? So if you're the minister, check, next indicator. But PNG and Solomon Islands, they have a different situation. Somaliland, a different situation. Now, as simple as this metric is, at least if you're the Minister of Health, you have a different decision-making process. If you are here, you have different things to worry about than if you're here, all right? You will have different capital decisions that you will make, all right? You will drill down. If you're here, you're going to drill down and say why. Is it distance? Is it workforce? Is it electricity? So you start to do different things based on these indicators, which I think is nice. Now, here's a real-world example. This is what I wanted to get to. So in Timor-Leste, they went to their Minister of Health and said, you know what? Darndest thing. We have 3 hospitals that can do these bellwether procedures pretty reliably, and those hospitals cover about 50% of our population. And the minister said, and? And they said, well, we also have 2 hospitals that are not bellwether capable right now, but if we just ramp them up, we'll have 80% coverage of Timor-Leste, all right? So that's just a very simple example of where now the Minister of Health can say, okay, didn't fully understand that that was the issue. Let's not build any more hospitals, but let's look into these 2 specific district hospitals and say, what do I need to do to get those up to the point where they can do the bellwether procedures? Now, I won't bore you with this. They went through the other indicators, and I was really impressed that they were willing to share data in some of the countries that didn't necessarily make them look good in relationship to their partners. But Emmanuel Mikasa is the one who told me, he said, you're going to see some competition amongst countries in a region. So he said, when Zambia does this, you know, other countries are going to want to do this. And you know what? About 6 months ago, Zimbabwe called Walt Johnson at WHO and said, hey, yeah, you know what Zambia's doing? Could you help us do that? Because we want to do what Zambia's doing. So he was absolutely right. And here's one example. In the forefront is perioperative mortality, all right? Low green, high mortality. In the back is access. So these are countries that have theoretically better access to surgery, and this is their perioperative mortality. These are countries who have poorer access to surgery. Now, this isn't statistically significant, and I only show you this as an example. This was our first data gathering attempt. But this is the type of data that over 5 or 10 years, you're going to see trends, and you're also going to clean up this data and see if it's real. So honestly, everybody's question is, you know, is these countries, is their perioperative mortality really that low? I don't know, but at least they're measuring it, and they'll get better at it, and next year they'll get better, and pretty soon we're going to have electronic solutions for how they collect data. And so, you know, if you never start on the journey, it's never going to be so good, but at least they're starting on this journey, all right? So I will summarize. I just want to go back to the 4 things that I think are critical from the Lancet Commission. 1, we had a clear vision. Universal access to safe, affordable surgical and anesthesia care when needed. At this point in my life, if I were to introduce one other word, it might be something around quality, but we won't haggle over that. Key messages. We had 5 messages. One that had to do with access, another with number of surgical procedures, this one with financial risk protection. This is very much an economic key message, all right, and a message that this is an investment and not a cost necessarily. And then the last key message was that driving home that surgery is part of healthcare. Don't stand up an isolated, siloed surgical system. It has to be part of the rest of the healthcare system. There's a community health component to surgery, there's a district level component, there's a tertiary component, and all of those things need to work properly. The third thing, these indicators. Really important these are collected. The World Bank, so at one end of the spectrum we have the World Bank who said, we like these, we'd like to collect them. But we can't stop there. WHO now has to look to the ministries of health and say, we would like this data, and we will then send it to the World Bank. Because if you're a minister of health and WHO is not asking you for that data, highly unlikely that you're going to start collecting it. So you know, I've been working with Walt Johnson at the WHO. I really, really want them to say, we would like this data from ministries, all right? Because you have to really change culture in these countries to collect this. And then this concept of a national surgical plan. All right, so just the concept that as a country you should be making a plan for surgery and that should be integrated into healthcare. You know, there's that famous quote from Alice in Wonderland where that cat that's sitting on the tree says to her that if you don't know where you're going, any road will get you there. All right, if you don't have a plan, you can just meander down any road and it doesn't matter. But until you have a plan, you don't know where to go. So I really think it will be incredibly helpful for countries to explicitly decide what do we want to do vis-a-vis surgery? What are our goals for 2030? What do we want our workforce to look like? What do we want our district level hospitals to look like? What do we want our financial risk protection to look like? All right. And I guess step 1 is a document. Step 2, Stanley and I were talking about that. How do you take the document and translate that into some kind of reality? And that's the next step, which we are just starting. So Zambia is at a point now where when they sign that document, then the next question is, okay, great, you have a document, what do we do with that next? And that's where I actually turned to Stanley and said, wow, we're going to need your help because your group here has done a lot more with implementation, and that's the type of expertise that would really help with that. So with that, I'll pause for questions. Thank you. It's really been an honor and a pleasure to be here, so thank you for inviting me.
In your national surgical plan, you had 5 things: infrastructure, service delivery, information management, financing, and workforce.
Mm-hmm.
I think there's a lot of people in here who are interested in workforce because we do a lot of capacity building around health workforce.
Yep.
Did the Commission address sort of the needs and how they might meet the needs of the development of the workforce? For example, did you talk about surgical task sharing or task shifting or training of that workforce as part of the Commission?
Great question. And that working group, as you can imagine, discussed and argued for hours over issues like that. So you've alluded to some of the key issues. So what's the role for what we might call mid-level providers, whether it's task sharing, task shifting? We like the word task sharing, and it might be a subtle difference from task shifting, but we like the word task sharing because in terms of accountability, an extended practice clinician or a mid-level provider really should be interacting with a surgeon, for example. So there should be some accountability relationship. There's a section in the report on that. We were agnostic to the extent that we did not want to say this is what you should do. We were very objective and said, here are the options, here's what some countries have done. You should look at it. There's also some data in the initial report, and actually we're just going to be submitting a paper with more data, looking at the cost of scaling up a workforce with that approach versus no, all we want is specialists. And you can almost instantly cut the cost in half if you incorporate mid-level providers, task sharing, task shifting, et cetera. So there's good economic, good financial reason. And in reality, within 15 years, there's no possible way, given how long it takes to train a surgeon from start to finish, that you can scale up in 10 or 15 years to the degree that we want. So the reality is, in my personal opinion, countries need to look at that seriously.
Great.
I don't want to be in a position of telling countries what to do, and there are many countries that is really grabbing the third rail, so I think you have to be careful with that.
Great. Dr. Forrest.
Yeah, John, congratulations on an amazing talk, but also it's a phenomenal feat in terms of what you've done for coordination and care in this area. I'm wondering if you could speak a little bit about culture. Obviously we have to be sensitive to culture, and what you're doing is essentially presenting a very coherent and cohesive plan, but it has to be done in a respectful way, and I can tell you that we have challenges from a cultural point of view in surgery on a routine basis.
Yeah.
And I'm wondering if that is something that you've had to deal with and if there's any strategies.
Good, really good question. And on a related, kind of related to that, what got me thinking of what you just said is a friend of Dr. Buddha's, Lubna Samad from Karachi. Early on in the process, I met with her and was talking about the Lancet Commission, and she said, John, how are you possibly going to have a document that is meaningful for 190 countries that, culturally, whatever, and that really struck me. I thought, my God, this could be a disaster. How can we possibly have a document that does that? And so I think we straddled that fairly well in the sense that we came up with principles like the National Surgical Plan. So we're not going into a country saying, this is what you have to do. All right, what we're saying is, it's probably a good idea to look at your infrastructure, look at your workforce, look at these things. We can help you with that, but we're not telling you, and the same thing with mid-level providers. It's a good idea for you to look at that. We're not telling you should have task shifting or task sharing, but let's actually talk about it. The other thing that I think is critical, and we've done this with, right now there's probably about 12 or 15 countries that we're actively working with at the ministerial level over national surgical planning. And we've been pretty open to say, look, we can't do this for you. This is your plan. You have to take ownership of it. And most of them, when you first say that, they say, oh, okay. Some of them haven't been willing to do it, and so we haven't proceeded with them. But I don't think you're going to be successful if you don't, A, give ownership to the country, B, accept that I'm just a visitor. We're here to help you, but we're not going to do it for you. And C, our group has said, we're not a funding agency. So if you want it badly enough, you need to take ownership of it, and you need to be responsible for funding it. Zambia was the best example. I mean, they did everything right. They took ownership of it. It was their project. We were there at their pleasure and helped them the way they wanted us to help. And it's amazing because it was our first effort, and it was the best that I can imagine. And so now we're working with some other countries, and we're seeing some of the issues. But if you don't get local ownership, if you don't have a multi-stakeholder approach, so if many countries have a lot of industry support, a lot of countries have a lot of NGO involvement, a lot of countries have a lot of private industry or private healthcare. If those countries don't incorporate those stakeholders, you can't have a national surgical plan that ignores that aspect. So a little long-winded, but all right. Any other questions?
We have a question from the cloud.
Great.
Do you think there's a risk that children will be inadequately represented in national surgical plans?
Absolutely. So the first thing I would say is everyone's underrepresented right now because there's no data being collected. All right. The second thing I would say is that I would push back on that comment by saying kids do have fractures and kids do need abdominal surgery. And the last thing I would say is you have to start somewhere. So I think if you went to a country and said, we would like you to keep track of 127 different procedures, Haiti couldn't do that. The Haiti Ministry of Health, there are many countries that just are not in a point where they can do that. So absolutely, at some point, keeping track of pediatric surgery is critical. But I think step number one is just getting the ministry to say we want to collect surgical data. And as I said, some of this data is going to be related to kids. So I don't think we've excluded it purposefully. It's just this is just the beginning.
Good morning, and thank you very much for your nice presentations. My question is that the Lancet Commission does a national surgical plan. What is the future steps you want to take? Like, do you want to make a protocol like of WHO of different regions, like Seattle or Europe or American, so that they can fix the protocol and every country followed that protocol and in the national surgical plan, like malnutrition's protocol and other protocol submitted by WHO or CDC, and the whole of the world planning that country. Because I can see that that plan is going on in the 3 countries right now: Zambia, India, and Cuba. So, do you have any future plan to implement through a WHO or other things so that whole world go like a
Great question. Very good question. Yes, we do. So the Pacific Islands have already, they're a step ahead of almost every region. So as a region, the Pacific Island countries have said, we are going to do this together, all right? And they want to embark on national surgical planning together, and they want to benchmark against each other. And that's a great template because, again, I don't know that a central body can make this happen. So we just had a meeting in Latin America, in Brazil, about a month ago. And the objective of that meeting was to say, okay, in Latin America, what do you want to do? Again, it is, we shouldn't be telling anyone what to do. So our approach has been, look, those of you in Latin America who feel passionately about this, what do you want to do as a region? How are you going to get your ministries of health to do this? We can help, but we're not here to tell you what to do. Now, Walt Johnson has been wonderful at the WHO. So in terms of getting WHO involvement, absolutely. To whatever extent that they can, I'm all for it. But I really think it's incumbent upon, first, sovereign countries to make a commitment, and then secondly, regions to make a commitment. So the EXA community in Africa, East, Central, Southern Africa, there is an EXA community. They have started to talk about, should we start to do something as a region? CASEXA is the college that is in the EXA region. So I think our goal is to help regions, to be an enzyme or a catalyst to help regions do this themselves. Because honestly, whether it's the Lancet Commission and 20 folks or the Program on Global Surgery with 20 or 30 people, there's no possible way we can do this in 190 countries. I think every region and every country is going to have to take responsibility for that.